Assalamu alaikum. Welcome to Basic Critical Care Nursing. This session aims to provide nurses with an overview of critical care nursing practice. At the end of this course or session, you will be able to identify the roles and responsibilities of critical care nurse, identify the principles of critical care nursing, identify the importance of nursing care plan, state the emergency medications during Code Blue, provide endotracheal tube and oral care, interpret ABG results, CVB monitoring, and identify and prevent pressure ulcer injuries. So, what is it like to be a critical care nurse? Being a critical care nurse means working with critically ill patients, longer duty hours, mostly working in highly stressful situations, and be a critical thinker and fast learner, which means that you will be, as a critical care nurse, you will expect to see complicated cases. You will be working more than 8 hours, maybe 12 hours, sometimes even go beyond 14 hours. You will be working in highly stressful situations, such as you will be having 2 patients to care for, 3 patients. Maybe your patients will be coded. Maybe you will be having so many procedures to be done at the same time. So all of that, plus you have to be critical thinker where you will be, you should be able to uh, prioritize your patients, think which patients will be needing a care first, fast learner. You will be like action. You have to work fast, you have to learn fast, you have to think fast. You have to think, like, for example, you will go inside and you will start receiving your endorsement early in the shift, and while you are doing endorsement, you just, with a glance of a look, you will be able to pick if a patient's in a critical mood, or maybe patient need faster action. So you will pick, you will even you will just pass and see a monitor, and then you will be able to pick if a patient in critical condition currently and you need any further management. So the quality of care provided varies, and the importance of it's important to all critically ill patients. Therefore, critical care nurse must be equipped with the needed knowledge and skills to perform all tasks, which this presentation will help you to be equipped with, inshallah. So to be a critical care nurse, you have to have some basic skills or basic abilities that it will help you to move on from just or from general nursing to critical care. So first of all, the passion for a new job or passion for the job itself. So if you don't feel the desire, if you don't feel that you wanted to work really in critical care, you will not be able to be productive. You will not be able to really give all of what you can, or your abilities, it will not be seen very well. It's not just a job, it's really a passionate thing. You have to feel it, you have to feel it inside you. The second one, it's able to work on a team. So working on a team, nursing, it's never be a solo or single person job. It's always a team. It's the nurse is always the center of all teams. It's the nurse is always the link. So you have to feel that you will be able to communicate with other people. You will be you should be able to think how other people thinks. You have to understand how other allied health services, how they wanted things to be done. So you are, as a nurse, always the link. Number 3 is the general nursing skills. You are already here in this course. That means you already have your basic nursing skills, which you already had it in the basic studies, the bachelor degree or diploma degree. So you are equipped with the fundamentals of nursing, where you just need to upgrade yourself from being general nurse to go further in your career to improve yourself, so you will be able to manage critical situations. Then you should be able to face difficult situations where we said already it's the stressful situations where different patients, different healthcare professionals, you are dealing with all of them. You might need to deal with more than just one patient or two patients at the same time, so it's difficult. So as a nurse, as a critical care nurse, you have to be able to prepare yourself how to be in this situation, in this a place where you can handle all that situations. And again, nurses are keen observers. We are I think we consider ourselves best people to observe things. We can observe the changes on our patients. We can observe the changes in the situation of all the departments, so we can prioritize, we can assist. So we are critical observers. We are able to evaluate changes of the situation itself. Again, you cared about all the patients. You cared about the hospital where you work or the department where you work. You cared about other health care professionals. Then you have to understand, or you have to do care for yourself. You have to be able to think how to manage these stressful situations after work. What you should do, we should not bring our stress from work to home, or we take all of that harmful things outside the work. No, we have to think about it, that we should take care of ourselves also, that we should be uh, released. Because if we always stressed, if we always feel bad, if we always feel that we handle more than our abilities, if we are not knowledgeable, then we will be also stressed. So you have to take care of yourself, in which will enable you to work even much better, in much competent, and much further, and you can improve yourself even further than where you are now. Then last point here, technical critical care setting skills, where this the focus of this presentation. So critical care units is the most common place where the patients dies. So we have to think about it also from the ethical point of view, and what are we accountable for. So we have to think how to be assistant for the patients, how to be able to resolve issues such as the conflicts in the department among the stakeholders, where we are the stakeholders with the doctors, with the administration, with the other allied health services. So frequently in the critical care units, issues arises. So we have to learn how to handle it. As nurses, as clinicians, we should be competent in all aspects of ethical decision makings. For example, we have to understand about the consents, who will sign it, how they will sign it. So the major source of conflicts are the behavioral issues, such as verbal abuse or poor communication between physicians and nurses or other allied health services. So end of life care also. End of life care, it's a major issue, where sometimes we people, the patients and their relatives, they have certain beliefs or in how they wanted to care for their patients if they know the patient is dying. So if we cannot understand end of life care from the perspective of patients and their relatives, we will not be able to provide such care for them. So it's ethical issue, ethical point of view. So things will arise here. So poor communication, if we don't know how to communicate with others, this also will make things worse, will not be helpful for the patients in and will not be helpful for the patients when we are trying to provide quality care. So lack of knowledge and education of ethical issues, that's the major issues to be resolved here. So to make ourselves, or to prepare ourselves in ethical points of view, and to be accountable in critical care, so we have to be educated. We have to learn about different ethical issues. We have to learn about the policies the hospital the government providing to solve some sensitive ethical issues, like for example DNR. What's your perspective for DNR? What the patient's perspective to DNR? What the doctor's perspective? So if we understand all of that, then it will be easier to solve such a situation. But if the patient's perspective different than others, if they don't agree, for example, for DNR, and then from the hospital there are policies, so what should we do? As for us nurses, we are not decision makers here. We are the one executing such things. So we should also arise these issues to our superiors. So involvement of the higher authorities, or like charge nurses, supervisors, or administration in this situation will help us to understand and solve it. So these are the barriers where nurses should resolve and should understand in the ethical issues. There are different ethical issues we should consider and should learn about. The consent. The consent here, who will sign the consent? Patients are unconscious. They cannot decide for themselves. So who will decide for them? Are they the family? So we cannot reach the family. So what will happen? So there should be a protocol. So if we are new nurses, we are working critical care area, we can, for example, from general departments, the patients are conscious, relatives always there. It's not like the critical care area. So we have to learn and read more, so we will understand how to solve this kind of issues. Organ donation, patient advocacy. Patient advocacy, I think it's the turning point for nursing in Kingdom of Saudi Arabia, where we have to think about it. We are not, we are the new nurses. We are the new generation of nursing. We have to be advocate for our patients. We have to think about it from point of view. We are the shield for our patients in the hospital, because we are the link for all allied health services, physicians. So we have to be the shield for the patient. We are the protectors. So to be advocate for the patient, we should be knowledgeable. We should be certain in our decisions. We have to be aware about different policies and protocols. We have to know about patients' information, like you cannot protect the patient if you don't know about the patient, him or herself. So we have to be aware totally about this. Like, for example, if doctor, he will tell you, continue this antibiotic for another 5 days. But you know that antibiotic, it should be, there should be some blood test for renal function test. So if the doctor will tell you, maybe the doctor thought it's already done or something like that, and just like forgot. So for you as a nurse to be advocate for that patient, you will tell the doctor, sorry doctor, I cannot continue this medication unless we do renal function test for this patient. After the results, we will check. We can continue or change this medication. So we are advocate for this patient. So in general, about the ethical issues, we have to think about it, that we are helping patients. We are giving and providing better quality of care for our patients. So finally, in order for us to improve ourselves in providing ethical care, we should consider further education, better communication, and improved policy. The roles and responsibilities of critical care nurse, or we can say the job description of a critical care nurse. I will go through it for you. Assessing patient's condition and planning, implementation of care plan, provide direct comprehensive bedside care, treating wounds, assisting physicians, able to connect equipments and patients as ordered, interpret data, observing and recording patients' vital signs, ensuring that ventilators, monitors, and other types of medical equipment function properly, administering intravenous fluids, collaborating with the fellow members of the critical care team, responding to life-saving situations. All of that, we think about it, it's the job description where I will go through it from a different angle. I will explain it to you, for example, the assessment, how you will assess your patients, so you will be able to understand how to create a care plan. Acting as patient advocate, documents appropriately, so documentation here, ensure patient safety, follow the policies and procedures, and the principles of critical care nursing. So we have to anticipate nursing care. Here, this anticipation, we can anticipate when you know how to assess your patient. At the end, you will know what's going on with your patient and what I expect to see. That's the nursing care plan. Early detection, expertise. You will be expert, inshallah. After you finish this course, you will be a little bit expert from the knowledge wise, and when you do your practice in critical care units, you will be even further and improved nurse, inshallah. Supportive care, communication, collaborative practice, preservation of patient physiological defenses, prevention of infection, crisis interventions, stress reduction, and ethical principles. So the assessment, the evaluation of physical functioning is the valuable in critical care units to help inform patients' recovery after critical illness, to identify patients who may require interventions, and to monitor responsiveness to such interventions, where when we do our assessment for any patients, and sometimes we think about the assessment is something it's so big for us as nurses, maybe we don't do it properly. Just go slow, think about it, and think when you go and enter the room of your patient, and you will just say your patient, "Hi Baba, how are you today?" This is assessment already. So we are thinking assessment is so difficult thing for us as nurses, but actually it is very easy and we are doing it. You go and check vital signs, that's already assessment. You go check your IV cannula, that's already assessment. So you just choose the best approach and systematic approach to assess your patients. So physical examination of the patients and their observation can often occur together. So a systematic approach must be used and a head-to-toe system is appropriate. So in different departments, we are thinking like, for example, in emergency room, they don't use head-to-toe. They use in trauma patients, they use primary survey and secondary survey. So head-to-toe is the general one, where it can be applied anywhere. So this systematic approach will help in each section focus in history, clinical examination, and observations. So always history. The history is the first thing you do when you are assessing your patients. If the patient is unconscious, how you are going to deal with this patient. So paying attention to some details, simple details that patients are giving, or if the patient is unconscious, you will check in the old file, maybe the patient's relative. So it will help you to plan. It will give you good idea, big picture for whatever going with the patient. So you will think, okay, the patient had no chest trauma, for example. And when you do chest auscultation, you will find diminished air entry to one of the lungs. That means, okay, I know now there is something wrong with the lung, right side or left side. So fast action to be taken. So from here, this is the assessment. When you are assessing your patient, you will plan the care. Each section, as we said, is focused in different details, but the most important history, then you examine, then you observe. So we will start with the history taking. If the patient is awake, first approach your patient, tell your patient, my name is ABC, and I'm going to assist you. I will ask you some few questions, and then according to your answer, we'll go further in your examination. So you will ask about the past, present history, current medication. If they have some medication with them, they are using medication, that means they are with chronic diseases. So you will expect, like, if they are having hypertension or hypotension previously, they are managed with that. So you will check vital signs. You will know that vital signs should be, it will be different from the normal. So you should expect something with that one. If the patient is unconscious, then the most important, ask for old file, old reports. Maybe the family, they have old summary for his conditions. And if the electronic system is there, then you will find the old file in the system itself. Glasgow Coma Scale is basically to assess level of consciousness of your patient. This tool is helpful for all critical care departments. If patients with head injuries or sedated, we should remember the highest to get for fully conscious patient is 15, and the lowest is 3. For unconscious patients, for patients with 8 or less, Glasgow Coma Scale will be highly indicated for intubation. So if we will assess our patient and then we found the patient with 6, that means immediately you have to prepare for intubation. So with each section you are assessing, maybe you need to do fast action. Maybe sometimes you can delay that action, delay your examination. Maybe you can delay the moving to the second section in the assessment. Number 3, respiratory assessment. The respiratory assessment for patients in critical areas is very significant. Therefore, staff nurses should learn using stethoscope and how to auscultate. Breath sound will indicate the condition of the lungs. For us as nurses, as beginners, I suggest that we will learn what is the normal breath sound, what is the abnormal breath sound. So this will give you as starting point, as the foundation for your expertise. So you will be able to report in your nurse's note, you report to your doctors that, okay, doctor, when I auscultate the right lung, I found diminished air. So you will call your doctor. I did not hear any sound. When you go further in your, you will become expert in nursing. Then that's the time you will be able to identify different sounds, wheezing, crackers. So you will be able to decide. I tried to attach some sounds, but I was not able to prepare it. And maybe you can go to YouTube and found the breath sounds and also the heart sounds for S1, S2, S3, S4. So for the respiratory assessment, also you should include airway. You should examine the airway. So to be examined along with the breath sound. So it will give better picture. History of intubation or tracheostomy, insertion. Also, it's important because you will know this patient had some history of trauma, history, or maybe indicated for some reason was intubated, maybe elective, maybe the patient did some surgery, so they did intubate him or her in the this operating room. So it's very important. Then circulation assessment. It is important as well to perform assessment in daily basis. Assessment will include heart sounds, as I said, S1, S2, vital signs. For the vital signs, as it's very simple, very basic for nursing, but sometimes we are forgetting that the use of manual vital signs check, because technology now, and we are using this technology, monitors, PP apparatus, electronic ones, but keep in mind, in some conditions, some patients, that you need to check manual blood pressure, because if you are checking and patient is restless, you will not have correct reading. Remember that. If the patient is the heartbeat it's not regular, sometimes it will not give you a good reading. So you should do a manual blood pressure check. Same thing for the pulse or the heart rate. The heart rate, the pulse oximeter will give you reading, but if you will check manually, you will be able to know the characteristic. You will be able to know if this heartbeat is weak, if it is the slow. So you will be able to identify the characteristic of the heartbeat. So it's very important that we have to know how to do how to check manually. Like pulse oximeter will not work on some skin colors, and sometimes here in Saudi or anywhere in the world they put some coloring in the nails, so it will not be easy to read. So doing heart rate check manually, it's very important also. Also, you need to check for the circulation, the peripheral edema. If there is a peripheral edema, that means that it's a sign for prolonged supine position for the patient. So that means you need to understand if there is edema, that means patient in need for turning. So it's also again important. Next one is the abdomen and nutritional assessment. It's daily check for the abdomen, especially if the patient had surgery or there is drains or wounds. And remember the bowel movement, you should auscultate before the percussion, and it's the only system you need to do that. You need to do the auscultation before the percussion, because the bowel movement, if you will percuss, it will be diminished, then you will not be able to auscultate. So it's very important. And again, because you are in critical care area, patients are in bed, that means there is lack of movement, and patient may be on muscle relaxant, that means the muscles are not moving properly, that means the patient might develop constipation, which means that you need to check the nutrition, the food, the diet of your patient, what kind of diet they will have. Maybe they will have liquid, then what kind of liquid food they will have. If you know your patient have, when you do the renal assessment, maybe the patient with renal disease, that means you have to understand that your diet, the patient diet, need to have low protein. So according to your assessment, when you are assessing, it will give you a really good picture that you will help your patient. So some patients you need to check for the body mass index. That means you need to check the weight, the height. It's very important also. It's not only for the nutritional assessment, but even for the medication to give the correct doses. Then the renal assessment. Renal assessment every hour. You have to check also output, because if the patient having good kidneys, that means they have to have certain amount of output recorded. So if it will be reduced, that means there is something wrong. Maybe patient dehydrated. Maybe you are not giving enough fluids for your patient. Maybe there is some issues arises with the patient. For example, if the patient admitted with the sepsis, so if the patient admitted with a septic shock, means that maybe the patient developed renal failure. So you have to understand the assessment. It's very important here as well. So most patients with catheter as well, maybe your patient developed UTI. We have to check the urine itself when we are taking the output. So how's the urine? The color, is it cloudy or clear? Is it brownish? Is it with blood? So it's very important to have that one assist, so you will be able to do further management. So if there is UTI developed only in critical care department, that means you need to do maybe patient in need for antibiotics. Blood test. It is important as well to review the blood test daily to give a good picture on renal function, electrolyte status, CBC. If the patient came with trauma, when you do CBC, you will see the hemoglobin low. That means patient still bleeding somewhere. So you need to do fast action. If the patient is bleeding, that means patient may be in need for blood. So blood grouping, it should be the baseline. All this one baseline, you have to prepare it in your for your patients. So what is the group of your patient? Blood group. Cross-matching may be to be done. Cultures. Sometimes the patient came with some sort of infection and admitted. Doctors, they will decide to give some antibiotic, but we keep in mind that blood culture reports, it should be there because it will help to choose which is the best for the patient. Knowing the changes will help to manage situations easily and on time. Finally, after assessing all previously mentioned points, it will help you to formulate a plan of care where you will prioritize your patient's needs. As well, it will help you to care for your patient with daily routine and daily in every shift assessment. Sometimes you need to check or to assess one section more than just one time because you need to be sure. Sometimes patient's condition changes, so you need to do the reassessment again. We should not forget that reassessment after any procedure or medication administration or abnormalities in observed will help to manage again on the right time. Priorities may change between time to time. For example, patients recovered from the chief complaint but developed pneumonia. So your priorities here changed. So assessment in every shift is important. Monitors will not give you a full picture, so combine your work between monitors, findings, and your personal assessment. In each department, there is medication, emergency medications used in intubation, used in to manage some situations. Here I will mention the medications, but we'll go through some few of them. Morphine, norepinephrine, labetalol, lidocaine, propofol, nitroglycerin, ephedrine, epinephrine, dobutamine, dopamine, amiodarone. All those medications available as emergency medications, sometimes more or less in different hospitals according to their scope of practice. Maybe they give the hospital protocols are different than others, but this is general emergency medications to be used. Here we will go in details for first one is morphine. Morphine indicated to relief of moderate to severe acute and chronic pain, pain related to MI, relieves dyspnea of acute left ventricular failure and pulmonary edema. Usually the infusion dose is 100 milligram over 50 ml if it's infusion. Remember, respiratory depression may occur if the medication is not cleared from the body. Renal function should be monitored. So you are giving some sort of medication that related to that medication, you need to do some other check, blood test or assessments. So in case of morphine, you need to check for respiration and renal function test. Amiodarone. Amiodarone is used for life-threatening ventricular arrhythmias, and the infusion dose 1,200 milligram over 500 ml. Its extended load, 7 days is required. Observe hypotension, so vital signs to be checked, and AV heart block. Monitor QT, so you need to do again ECG with giving this medication. So you have to monitor the patients continuously on the monitors, or you need to do ECG continuously in order to know if you are giving this the right way or not. Sometimes they're giving bolus for amiodarone, so you have to observe. Should have baseline thyroid function studies. So again, you will need thyroid test for the patient, hormone test. So you'll be able to see if there is any side effect of this medication on the patient. Dobutamine It's for short-term IV therapy of congestive heart failure and low cardiac output states. Infusion dose is 250 mg over 250 ml. Inotropics, it's inotropics agent, and be careful with tachyarrhythmias and ischemia with this patient. Dopamine, the indication of dopamine is to increase cardiac output, blood pressure, and urine flow as an adjunct in the treatment of the shock persisting after adequate fluid volume replacement. Infusion dose is 800 mg over 500 ml. Be careful with this one again with the tachyarrhythmias and ischemia. Epinephrine. The indication of giving epinephrine is for anaphylactic reactions, cardiogenic shock, and cardiac arrest. The infusion dose is 4 mg over 250 ml. Be careful with this medication as well for tachyarrhythmias, ischemia, and the hyperglycemia. So you need to do random blood sugar. Moving to endotracheal tube and oral care. It is common practice for critical care patients to require mechanical ventilation, which is initially achieved via the insertion of ETT, unless contraindicated. The main indications for patients intubation in the critical care are to secure or maintain a clear airway, to prevent aspiration of gastrointestinal tract content, to enable adequate tracheal suctioning, to apply mechanical ventilation. A key component of the management of any patients receiving mechanical ventilation is appropriate care and securing of the endotracheal tube. It is essential that the position of ETT remains stable for a number of reasons. The ETT is fulfilling the function of patient's airway. So patients with ETT, it's opening their airway. So we have to be sure to give proper care for that one. To ensure the access for optimal ventilation. Endotracheal tube movement within the trachea may cause trauma and be a source of significant discomfort to patients, and it may cause them to be restless. ETT, it will help access to oral cavity to allow oral hygiene procedure. So if there is oral ETT, that means you'll be able to do oral hygiene easily. A recognized risk to intubated patients is the acquisition of ventilator-associated pneumonia, which is called VAP, which increases morbidity and mortality. Regular and effective oral hygiene includes the brushing of teeth, gums, and tongues, has shown to reduce the risk of VAP, and their securing device can obstruct ETT, and their securing devices can obstruct access and the view of the oral cavity, preventing effective oral care. So for us as nurses, as professionals, we should give this care for the patient. ETT care, oral care, it's very important and it's really crucial for your patient. Reducing the VAP, and you are giving hygiene, proper hygiene to your patients. ETT and oral care includes maintaining safe cuff pressure. Any patient who require an ETT requires regular measurements of the pressure within the cuff. So we have to check the cuff regularly. This is to ensure there is an adequate cuff seal to enable effective ventilation without exerting unnecessary pressure on the tracheal mucus. So ETT, it's positive and negative for your patient. If it is not in the position, it's not in the right place, it's not inflated, the cuff is not inflated properly, then Maybe patient will not be given proper ventilation. Maybe the patient will have trauma. So this is the negative point of that ATT. Preserving skin integrity. Because the patients with the devices such as ETT, and you are securing the ETT around the lips and around the head itself, so it might cause pressure ulcer around the device. They call it device pressure ulcer. It's acknowledged and it is known for all the patients in the hospital, and it can cause damage to the skin and mucosa due to the rigid materials from which they are manufacturers, thus creating pressure on the soft tissue. So adhesive tapes to be used to secure the ETT. Devices may irritate the skin, especially where there is edema around the device. It is also recognized that correct position and appropriate fixation and stabilization of ETT can prevent the device pressure ulcer. So it's very important to know how to fix it. It's not just fixing. It is known that the occurrence of pressure ulcer creates pain and discomfort for patients and can result in the extended hospitalization. It is essential that when an ETT is in place, regular assessment and documentation. When you are documenting the ETT itself, the level of the ETT, the cuff, it's inflated or not properly, it's clear airway, it is how's the skin condition around the device. So it's all needed to be checked and assessed. If there is any abnormalities, what actions taken, then you have to document also to prevent pressure ulcer or to continue proper ventilation for your patient. ETT should be assessed every 2 hours or according to your hospital protocols. There are elements that need to be considered in the assessment process, which is the anticipated length of ventilation via ETT, level of sedation, and patient's compliance, skin integrity around lips and face, including the presence of facial burns, trauma, or any surgery, the presence of raised ICP. So there are different methods aimed to at ETT stabilization. First, you can use adhesive medical tape. You can use white cotton tape. You can use foam Velcro straps, or you can use endotracheal fixation device. There are some companies providing different types of fixation. Some of them is more advanced, but we still can use anyway. But any devices available in your hospital, you can use it. But assessment, then management, and always document whatever you do. Change dressing tapes every 24 hours or as recommended in your hospital protocol. It is not recommended to use white cotton tape in critical care patients whose anticipated length of intubation will exceed more than 6 hours or are in a high risk group of developing pressure ulcers. So check, observe, and document the size and position of the ETT every shift. Ensure position of ETT is assessed regularly. Check the cuff pressure. Following mouth care or direct care, check the position. So whenever you do mouth care for your patient, then you have to check the position itself, it's correct or not. Oral care. Comprehensive oral hygiene has constantly been recognized as critical to the prevention of pneumonia in the hospitalized patients. So even regular patients, not critical patients, they need oral care. That's why we call it morning care. We provide morning care. We ask the patient, come, get up from your bed, go to the toilet, take shower, brush your teeth. So all of that, what we are doing for general patients, then we need to do it for critical patient. By in critical patient, we are doing it by ourselves. So we have to understand the materials to be used, how to use it. There are different guidelines from, for example, internationally CDC, from your own hospital, infection control in the Ministry of Health. There are guidelines to help you in how to manage and prevent infections. So the CDC guidelines for preventing healthcare associated pneumonia recommend making comprehensive patient oral hygiene standard practice as a VAB preventing strategy. So in each hospital, you need to have some protocol in prevention of VAB. So routine oral decontamination is an effective method for reducing VAB by decreasing the microbial load in the oropharyngeal cavity. It has been found that incorporation of routine oral hygiene into standard practice may reduce VAB as much as 60%. So the recommendation for oral care procedure: assess the oral cavity, conduct an initial assessment during admission. So when you have your patient for the first time, you need initial assessment. Then you need daily assessment for your patient oral cavity. You need to assess the lips, oral tissue, tongue, assess the teeth, saliva of each patient. It's important on a medical, especially those patients in mechanical ventilation. You have to assess their all those points and to document that assessment. Then maintain saliva. Interventions in the unit-specific protocols should be implemented that assist patient at risk of VAB is maintaining saliva production, oral tissue health, and minimizing development of mucositis. So there are protocols to maintain saliva of your patients. Sometimes they are giving some medications for that one, so you'll be able to monitor that saliva. This one because the saliva provides both mechanical and immunological effects, which acts to remove pathogens colonizing the oropharynx. The next recommendation is elevate head. Unless it's contraindicated, keep head of patient of the bed at 30 degrees and position patient so that oral secretions pull into the buccal pocket, especially important during such activities as feeding and brushing teeth. This elevation helps in preventing reflux and aspiration of gastric contents. Oral secretions may drain into the subglottic area, where they can become rapidly colonized with pathogenic bacteria. The next recommendation or strategy, subglottic suctioning. Its patient oral and subglottic secretions should be suctioned continuously or intermittently, with the frequency depend upon secretion production. This to minimize aspiration of contaminated secretions into the lung. As here to conclude this point, here we have different strategies to use or to do in the department in the critical area, where all of it to prevent colonization of the bacteria within the oral cavity. So if it's colonized, then the patient will develop where your patient will extend the hospitalization, which is not good for your patients, especially intubated or critically sick patients. So there are different materials to be used, and it's recommended by different organizations. Chlorhexidine mouthwash, it's recommended to be used for cleaning. Oral decontamination with topical antimicrobial agents also can be used. Some recommendations with normal saline, so according to your hospital, what is the recommendation, which solution to be used for that? So start with it. The next one is the ABG. What is ABG? Simply, it's arterial blood gases. Arterial blood gases test is the measure of acidity or pH and the levels of oxygen and carbon dioxide from an artery. The test is used to check the function of the patient's lung and how well they are able to move oxygen into the blood and remove carbon dioxide. So it's very important that we will ABG, especially for ventilated patient. It's important because we will understand the lungs are moving the oxygenated or the carbon dioxide is more than the oxygenated. So what kind of actions you need to do for this patient? This test is commonly performed in the critical care area and ER settings. However, ABGs can be drawn on any patients on any floor depending on the diagnosis. So what is the difference between ABG and VBG? ABG is related to oxygenated blood and it's from artery. VBG is from the vein and from the level of carbon dioxide measurements. So it is the a VBG, on the other hand, tests the venous blood, as we said, venous blood, and can accurately determine pH and carbon dioxide, but is unable to provide reliable oxygen. So, as we said, it's about carbon dioxide and the relation to pH. For this reason, arterial testing has become the gold standards in the sick patients in the critical area, where they will use ABG, so they will measure the oxygenated blood. So ABG are drawn for a variety of reasons. This may include, and not limited to, lung failure, kidney failures, shock, trauma, uncontrolled diabetes, asthma, COPD, hemorrhagic, drug overdose, metabolic diseases, chemical poisoning, and other conditions. Maybe even more conditions can be included. What are the components to ABG, which is related to lungs? And it's important to know about that one. First is the pH. pH, the normal is 7.35 to 7.45. PaO2, partial pressure of oxygen, 75 to 100. Partial pressure of carbon dioxide is 35 to 45. Bicarbonate, HCO3, 22 to 26. Oxygen saturation is 94 to 100 percentage. So focusing on the respiration. So if the pH is low, carbon dioxide is high, and normal HCO3, you see it's respiratory acidosis. On the other side, respiratory alkalosis, pH is high, carbon dioxide is low, and HCO3 is normal. So this is how you will interpret the ABG results. It's also, you can see the metabolic acidosis, metabolic alkalosis for patients. So it is how you will measure it, pH, carbon dioxide, HCO3, O2, like that. So it's important to understand, memorize how you will interpret this, the ABG. Now we are moving to CVP monitoring. Measuring central venous pressure. First, place the patient in the identified position and confirm 0 point. Intravascular pressure are measured to the atmospheric pressure at the middle of the right atrium. This is the 0 point or external reference point. Number 2, position the 0 point of the manometer at the level of the right atrium. Turn the stopcock so that the IV solution flows into the manometer filling to about the 20 to 25 centimeter level. The turn of the stopcock so that then turn the stopcock so that the solution is in manometer flows into the patient. Observe the fall in the height of the column of fluid in the manometer. Record the level at which the solution stabilizes or stops moving downwards. This is the central venous pressure, and then record the CVP and position the patient at the correct position. The CVP may range from 15 to 12. Then assess your clinical condition, patient's clinical condition. Change the measurements If there is any changes in the measurements, always interpret. Then you record it and document it. The charting, always chart the location of the insertion site, type and the size of the needle or cannula used, time of insertion, appearance of the needle insertion site, and then you will document. And important also, when you document the needle insertion site, observe infection signs. It's not only in the CVB, in any tube inserted in your patient, always check the surrounding. If there is any infection signs, then you need to do some actions, either remove it, inform the doctor. If it is check vital signs, if there is temperature, then maybe patient developed some kind of infection, so maybe in need for blood culture or in need for antibiotics. So keep your observation always. If you observe that, we always talk about assessment. So you are assessing, doing action, then reporting if needed, or documentation. Pressure ulcer injuries, identification and prevention. So pressure ulcer, the stages. First, stage 1 is non-blanchable erythema, intact skin with non-blanchable redness of localized area, usually over a bony prominence. Darkly pigmented skin may not have visible blanching. Its color may differ from the surrounding area. The area may be painful, firm, soft, warmer, or cooler than the adjunct tissue. Then the stage 2, partial thickness, skin loss of dermis, presenting as the shallow, open ulcer with a red-pink wound bed, without slough, intact or open ruptured serum-filled blister. Stage 3, full thickness, skin loose, subcutaneous fat may be visible, but bone, tendon, or muscle are not exposed. Slough may be present, but does not obscure the depth of the tissue loss. Undermining and tunneling may be present, and depth of the stage 3 varies by anatomical location. Stage 4, full thickness tissue loss with the exposed bone, tendon, or muscle. Slough or scar may be present on some parts of the wound. Tunneling and undermining are often present, may be extending into muscle or supporting structure, making osteomyelitis possible. There are unstageable pressure ulcer. The depth is unknown. Full thickness tissue loss in which the base of the ulcer is covered by slough, yellow, tan, gray, green, or brown, and or scar, tan, brown, or black in the wound. Until enough slough and or scar is removed to expose the base of the wound, the true depth cannot be determined. Last one, suspected deep tissue injury. Purple or maroon localized area of discolored, intact skin, or blood-filled blister due to damage of underlying soft tissue from pressure and or shear. The area may be preceded by tissue that is painful, firm, mushy, boggy, warmer, or cooler in comparison to adjunct tissue. Evolution may be rapid, exposing additional layer of tissue even with optimal treatment. Remember that staging should not be used to describe skin tear. Staging also should not be used to describe surgical wounds, arterial ulcers, or traumatic wounds. Risk assessment. Why it's important to do risk assessment? If you know how to assess your patient, again, for the risks, if you think your patient, because you are in the critical care area, you have to, you keep in mind that patients are not moving. We are not moving. If we as regular or not. We are not patients. We are normal people, not in the home. If we don't move more than 2 hours, we will start having pressure ulcer. Therefore, your patients, they are high risk, in high risk zone. So use the assessment tool used to identify patients' potential for or actual risk to developing pressure ulcer. Assist with targeting appropriate interventions. So for each stage there are different interventions. So you have to target which stage, what the correct intervention for that one, and proceed for that. Risk assessment tools should be conducted on admission and repeatedly, regularly, as frequently as required by patient acuity. Reassessment must be completed if there is any changes to the patient's condition. Do not rely fully on the results of the risk assessment tool alone when assessing an individual pressure ulcer risk. When using risk assessment tool, select a tool that is appropriate to the population, which is valid and reliable. That means you have to use the correct assessment tool approved in your own area, either a Braden scale or different scale like Norton scale or so. So in conclusion, knowledge is a powerful tool to advance our career. This course covered basics. We give you only the information that you need to make you to make you start moving. It will not give you everything, so you have to improve yourself. You have to read. You have to advance your career, and in order to be skillful, you have to integrate knowledge into clinical practice. And I wish you all the best. And here are the references. Thank you so much.